So transplant and cancer immunology. So first, moving on to transplant immunology. Transplantation is the transfer of a graft or transplant cells from one side to the other. So you have donor and you have the recipient. Next, you have to talk about classification of transplants. So based on the organ or tissue transplanted, and on the you have kidney, heart, skin grafts, etc. Based on the anatomical side, if you have skin graft, for example, you take it from the skin and you place it on the skin. So you place it on anatomically normal side, that is orthotrophic graft, and heterotopic grafts you place it at an abnormal site, so thyroid tissue in a subcutaneous pocket, etc. Next, you have vital grafts and static grafts. So vital grafts are required for the recipient to survive, such as heart transplant, lung transplant, kidney transplant, etc. Whereas static grafts such as bone transplant, they're non-living structures, they just provide a scaffold. Next, you have autograft. So if you take a graft from the same person, for example skin, and place it on the same person, that is an autograft. Isograft is, or syngeneic graft, is between genetically related monozygotic twins. Next, you have allograft, which is from human to human or pig to pig, etc. Same species. And xenograft, it is from a different species. So baboon heart into man, etc. Next, you have histocompatibility antigens. So histocompatibility basically tells you whether a graft will be accepted or rejected. So autografts and isografts are generally histocompatible, and the other two are histo-incompatible. So transplantation antigens are antigens against which recipients would mount a host response. So you have MHC molecules and AB and RH blood group systems. So first you have minor histocompatibility antigens, that peptides from normal cellular proteins, and the immune response against these MHA is weaker. So one exception is when a male graft is used in a female patient. This is called Eichwald-Silmser effect. This is because male graft tissues, they have a Y chromosome which codes for a histocompatibility Y antigen, which starts a different effect in the females. So male to female graft is rejected more, but female to male graft is rejected less. Next, types of graft reaction. You have hyperacute, acute, and chronic. So hyperacute occurs within minutes to hours of transplantation. It is because of preformed antibodies. So already antibodies are formed because of a previous blood transfusion or whatever, and then they cause complement activation, leading to thrombosis and ischemic necrosis of the blood vessels. Next, you have hyperacute reaction, which is not a common problem in clinical transplantation because you already do cross-matching of blood group and HLA typing. Next, acute graft reaction. It is mediated by cytotoxic T cells. So what they do is they directly destroy the graft cells, or cytokines secreted by them induces inflammation which destroys the graft. So again, antibodies also, because of the cytokines, they contribute especially to the vascular component of acute rejection. Next, chronic rejection. It is manifested as fibrosis of the graft. So T cells that react against the graft alloantigens, they secrete cytokines which stimulate the growth of fibroblasts and vascular smooth muscle cells within the graft. So this is the brief summary. Okay, minutes to hours, weeks to months, months to years, and T cell mediated, antibody mediated, and also chronic DTH mediated, because these T cells that develop into delayed type hypersensitivity cells. Next, the rate of allograft rejection varies according to the tissue transplanted, how genetically different the individuals are, and also immunological memory, and also factors influencing allograft rejection. You have if you use an autograft to the same donor, or allograft to the first time, or allograft for second time. So based on that, you have autograft acceptance. So there is revascularization in days 3 to 7, 7 to 10 healing, 12 to 14 resolution. But in case of first set reaction, it is a type of primary reaction when an allograft is placed in the first time from donor to recipient. So healing is 7 to 10 days, right? Instead of that, you have cellular infiltrates that come, and instead of 12 to 14 resolution, you have thrombosis and necrosis because of the inflammatory cellular infiltrates. Next, second set reaction, rejection. If a recipient has rejected a graft by the first set response, another graft from the same donor, if it is transplanted, it will be rejected in an accelerated fashion. Next, moving on to mechanism of graft rejection, it is caused principally by a T cell mediated response to autoantigens expressed on the graft cells. So primarily MHC molecules. The class 1 MHC molecules are derived from protein synthesis within the allogenic cell, and class 2 MHC molecules are proteins taken up and processed by the allogenic APCs. So mechanism of graft rejection, first you have sensitization phase, which involves alloantigen being presented to the recipient's T cells. So T cells, they may recognize these by direct pathway or indirect pathway. Direct pathway is when the already graft cells have MHC molecules which are directly presenting them to the recipient's helper T cells. And again, indirect pathway is when the recipient's MHC antigen presenting cells, they take them up and then they present it to the helper T cells. Next, effector phase, there is delayed type hypersensitivity. So cytokines are secreted, they produce lytic enzymes and kill the cells, and also cytotoxic T cells, they directly recognize MHC1 molecules and they kill the cells. Again, these cytokines, they stimulate B cells to produce antibodies, which mounts an immune response against the graft, and then it mediates hyperacute graft reactions because they are antibody mediated. So lab tests, you can do ABO blood group compatibility and HLA typing. Next, you have phenotypic and genotypic methods. So phenotypic methods, MCT and MLR, so microcytotoxicity and mixed lymphocyte reaction. And also genotypic, you have PCR, RFLP, PCR, SSP, DNA sequencing, etc. Next, immunosuppressive therapy. So hyperacute rejection manifests severely and within minutes. So the treatment indicated is immediate removal of the tissue. Chronic rejection, so it is poorly responsive to treatment. And immunosuppressive therapy can be used sometimes. So corticosteroids, you have calcineurin inhibitors like cyclosporin, tacrolimus. Next, mitosis inhibitors like methotrexate, and mTOR inhibitors like sirolimus, etc. And again, monoclonal antibodies, CD2, CD3, CD4, you have OKT2, OKT3 and OKT4. And you have rituximab for anti-CD20 antibody and infliximab for TNF alpha. Next, graft versus host reaction is also there. So what happens is graft contains some immunocompetent T cells, recipient contains the antigens this time, and recipient is immunosuppressed. So what happens is it can be acute or chronic based on 100 days of transplantation. So clinical manifestations, so liver damage is there, skin damage is there, rash and GIT damage, diarrhea is there. And also in mice, experimentally it is Rundt's disease. So chronic GVH also attacks the above organs and it also causes damage to connective tissues. Treatment, you use glucocorticoid, standard treatment. Next, cancer immunology. Two types of tumor antigens have been identified on tumor cells, TSTA and TATA. So TSTA is tumor specific transplantation antigen. They are present only on tumor cells and they result from mutations in the tumor cells that generate altered cellular proteins. So cytosolic processing of these proteins would give rise to novel peptides that are presented with class 1 molecules, and they are induced on tumor cells either by chemical or physical carcinogens. So tumor specific, and for example ultraviolet light is an example of chemical carcinogen, whereas EBV induced nasopharyngeal carcinoma, it is, and several types of lymphoma, they are viral induced. And TSTS and ATS are not unique to tumor cells. They may also be expressed by normal cells but at a very low level. But in tumor cells, their level gets high. Oncofetal antigens are proteins, they are TATAs, that are expressed on normal cells during fetal life but not normally in the adult. So because of tumor cells mutations, there is reactivation of the embryonic genes, and examples include alpha fetoprotein and CEA. Next, non-oncofetal TATAs also are there. You use them as tumor markers. For example, alpha fetoprotein in hepatocellular cancer. And next, carcino embryonic antigens, CE and GIT cancers. Next, CA 120 tumor antigens, you have 125 ovarian cancer, 153 breast cancer, 19 you have various carcinomas such as colorectal carcinoma, PSA for prostate cancer, beta 2 microglobulin for multiple myeloma, and beta HCG for choriocarcinoma. Next, immune response against tumor cells. Both humoral and cell-mediated immune responses are induced by tumor antigens. So, number of tumors have been shown to induce tumor-specific cytotoxic T cells that recognize the class 1 MHC molecules. But the thing is, class 1 MHC molecules are decreased in a number of tumors, so T cells are limited. Whereas NK cells, because of expression of class 1 MHC molecules, so activity of NK cells is not compromised, but it is enhanced by the decreased MHC expression. So what happens is, inhibitory receptors of NK cells will not be functional in the absence of NHC1 molecule, so only activation is there. So it causes ADCC. So importance of NK cells in tumor immunity suggested by Chediak-Higashi syndrome in humans. And cancer immunotherapy, you have cell-based, antibody therapies and cytokine therapies. So cell-based therapies, so basically are removing the immune cells which can cause anti-tumor reactions. So you have Provenge for the treatment of prostate cancer. Next, monoclonal antibodies, you have rituximab, again CD20, use it in CLL. And again, bevacizumab, VEGF target, you have colorectal and lung and renal cancer. Epidermal growth factor receptor, you have cetuximab, used in same cancers. Next, cytokine therapies, use interferon alpha in the treatment of hairy cell leukemia, AIDS-related Kaposi sarcoma, etc. And also interleukin-2 in treatment of malignant melanoma and RCC.